Okay, good morning all. Welcome to this session of the 2024 Culture of Data Conference. Thank you all so much for joining us. My name is Ann Hill. My pronouns are she, her, hers, and I will be moderating this session. We also have Sudev with us, who will be managing the Zoom and making sure that the tech is running smoothly. Currently, you're all muted. But if you do have a question during the Q&A session, we recommend that you unmute. Of course, you're also welcome to put your questions into the chat, and we will be monitoring that as well. If you're comfortable in doing so, please add your pronouns to your Zoom name, and you can do so by clicking the 3 dots on your video square and selecting Rename. So we now, this session, I should say, has been generously sponsored by CDPH&E, so we thank them for their contributions to this conference. We have one presentation during this session, and they will present for approximately 25 minutes. And then there will be about 10 minutes for question and answers afterward. So a little bit about this presentation. So Alex Staracy is going to be talking about how she has used data from the National Longitudinal Survey of Public Health Systems and been able to visualize this data using the software of RShiny, to be able to, for the main goal, to allow users a quick and easy way to explore and compare public health networks across multiple attributes, including year of survey, rurality, type of jurisdiction, and local health department governance. I will now turn over the session to Alex to present her presentation titled A Tool to Visualize and Compare Local Public Health Network Structures. Alex, the floor is yours.
Thank you. You able to see this okay? Okay. Thank you all for being here. My name is Alex Staracy, and I'm going to present on some of the work that I've done creating an RShiny app. And basically, I wanted to create an interactive app to visualize and compare local public health networks. So Systems for Action is the group that I've been working with, also known as S4A. And their research focuses on better understanding health systems and using health services research with the aim of improving cross-sector collaboration in the public health sector. And a lot of the research surrounding cross-sector collaboration explores the ways in which we can encourage successful partnerships and policies by encouraging ongoing collaboration in public health across sectors. So to really understand the current landscape of the nation's public health infrastructure, S4A relies on primary data collection from the National Longitudinal Survey of Public Health Systems, also known as NALSYS. And the NALSYS survey gathers data from local public health officials about how individual communities implement a variety of core public health activities. So from this data, it's fairly easy to derive simple statistics and to analytically describe local engagement in public health activities. So for example, the percent of public health activities that are implemented, the types of organizations involved, et cetera. Sorry, I had a call. However, we're interested in better understanding the strengths and weaknesses of public health systems, as well as the ways in which a community can act to strengthen its public health infrastructure. And so to do so, we kind of need a more comprehensive understanding of each community's characteristics and its inherent limitations in implementing public health related tasks. So to better understand how to improve public health capacity, we have to dig deeper into which individual public health activities provide the most value, the roles of individual actors, or in this case, organizations in the network, and also how organizations collaborate to deliver public health activities to local communities. And so, as I mentioned, NALSYS collects information on local public health networks, and our data set consists of network data. So in the data set, we have a derived attribute called public health system configuration, which we also call cluster typology. And this attribute categorizes public health systems into basic categories based on scope, centrality, and density, and essentially defines a community's public health capacity as comprehensive, which is most effective, conventional, which is moderately effective, and then limited, which is least effective. However, this high-level attribute does not provide a lot of insight into how the most effective public health systems evolve and which aspects of the network are most critical in developing and maintaining a high-functioning public health system. So this project really aimed to visualize network data of local public health systems to address some of these knowledge gaps. The target users that I had in mind when I was creating this app was public health researchers that are focused on health systems and health services research, because I work in health services research. And this research will shed light on how to optimize the implementation of public health activities in local communities, and the visualization of rich network data can be really important in revealing which aspects of public health networks are the most critical and which characteristics of the network may be driving changes in the public health network structure. And so I was kind of forced to think about like, what are the goals heading into this project? Because when I started this program a couple of years ago, it was like, okay, what are the questions you have? And I was completely new to the field of public health and we had all this data, but I didn't really know where to start asking questions. And with the format that the data that we had, it was really hard to understand like the bigger picture of like what is important, like which types of relationships should I be interested in, and what is the impact of like how these types of organizational partnerships form. Like there are different ways in which maybe state health agencies reach out to local organizations or vice versa, but how these organizations pull each other into the network, so that kind of thing. So my high level goal was basically to perform exploratory data analysis and use the R-Shiny app to generate interesting research questions. The mid-level goal really focused on generating hypotheses and understanding variability in public health implementation. And then the low-level goal, which is like a more specific goal, is to use this app to understand the mechanism by which public health activities are implemented through specific actors. So for this project, I designed an interactive app to visualize and compare local public health networks. As I mentioned, NALSYS is the survey data that we use, and it asks local public health officials to answer questions regarding the community's implementation of 19 different core public health activities. And then for each activity, it also asks about the involvement of 14 different types of organizations. So here is an example from one of the survey questions. And basically, if a respondent were to answer yes in the first highlighted section at the top here, that would mean this activity was implemented in the community. And then the respondent is asked to fill out another question about what types of organizations are involved in performing this activity in your jurisdiction. The way that we define a tie is if two organizations jointly participate in an activity. So for example, if we saw that hospitals were checked here and physician practices were checked, we would say that they have a single tie for this specific activity, which is activity number 1. And then there are also 18 additional activities. So the strength of the tie is dictated by the number of activities that both organizations are jointly involved in. And because we don't know the direction of the relationship, we end up having an undirected network. So we can guess, for example, that like if state agencies are partnered with hospitals, maybe we think that the state agency was the one to reach out to hospitals for specific types of activities, but we don't actually know which direction that occurred in. So the data that we have is in a table where each item, so like each row of the data, is one local health department jurisdiction in a given year. And then within each row, we also have attributes of that respondent. So for a specific health department, we have the year of the survey, whether or not they're rural, the type of jurisdiction, so city, county, multi-county, et cetera. And then local health department governance, which is split into state, local, and shared governance structures. And then we can also derive network edges from the survey responses. And in total, there are 6 survey waves, and each includes approximately 600 communities. So in total, we have about 3,000 rows in our data set. So as I mentioned, there are 19 activities that we ask about in NALSYS, and I won't go into too much detail about the specific activities for now. But NALSYS is a nationally representative survey of communities that captures information about organizations that contribute to public health activities. And so they're asking local public health officials to answer these questions about the community's implementation of these 19 core public health activities. And each category, there are 3 different categories: assessment, policy, and assurance. And there are 6 to 7 questions that ask about each specific category. So for the assessment category, it's basically how well does your community assess public health and the public health infrastructure. The policy category is really like, to what degree does your community engage in public health improvements through policy, and what types of processes do they have in place for this? And then the category, which is the most rare type of category. So the fewest communities tend to have these types of activities, and the fewest organizations participate in these activities. Is there questions that relate to what degree does your community proactively target improvements in public health? How well do they communicate with your community? And how well do they kind of measure progress as well? So in visual design, I was encouraged to kind of draw out what I was doing in terms of like, what are the tasks that I'm trying to accomplish? What are the actions that the user would want to take? And then what are the targets? So like, how would these results be displayed? And the 2 primary tasks that I ended up with, the first one has more to do with what is the average network structure. So explore the average network structure and organizational actors across similar networks, but also be able to compare different types of networks. And these are shown in the visual design in terms of network topology, network density. And then I also wanted to be able to highlight the most and least central actors. So which types of organizations are most involved and which are least involved. And then the second task has a little bit more to do with the details, but explore and compare the mechanism by which local public health networks engage in cross-sector collaboration. And here I really wanted to look at what are the trends in collaboration? Are there specific actors that are important and maybe in specific types of activities? And also look at the strengths of ties between specific types of organizations in the network. So here's an example of the first iteration of the app, and I just wanted to quickly highlight a few of the features that I felt were important before I dive deeper into a use example. But there are 3 primary ways to look at the overall network topology and network density. So on the top, you have 2 options for the graph layout. It's a little bit different in my current iteration, but you have a force-directed layout here, and this basically gives you a sense of who the central actors are. So they end up near the middle, but every time you recreate a force-directed layout, it can change the orientation of the different organizational actors. The circle layout here on the right gives you a sense of which ties are the strongest, and it also makes it easier to see who is collaborating with who. And then I also created underneath this node link matrix, which highlights in more detail where the strongest and weakest ties are. So you can see, I'll get into this a little more later, but the yellow is like the weakest ties in the network, and the dark orange and red are the strongest ties in the network. So local health departments and hospitals have a lot of collaboration overall, is what this would be showing. So in my design, users can select public health networks to compare, and they can select and deselect attributes on the left-hand side. Average edges are derived from the user selection, so across activities and across communities. The visualizations show network topology, so either force-directed layout or a circle layout. And then underneath is the node link matrix. And then users can now further explore the features of the network by selecting network layout, edge weight encoding, node size encoding, and the filter search can be updated as needed. So my current design here, I'm showing an example here that I'm going to kind of continue with, but it's a comparison of rural and non-rural jurisdictions in 2018. So you can see here on the left-hand side, we have rural selected, and then all types of jurisdictions and all local health department governance. On the right side is non-rural jurisdictions in 2018. And by default, all the boxes are checked, but you can deselect or change selected boxes and then click this update filters button to generate the new comparison if you want to. And the visualization also defaults to show a force-directed layout, as you can see here, using edge weights relative to the overall network and a stable node encoding, so up here. The default edge width is based on the number of links in the single edge relative to all of the edges in the network. So between two organizations, they can share 0 to 19. And it's basically like a proportion of the number of edges shared between those two organizations relative to the total number of edges in the network. And then node encoding is just default. The default setting is to make all of the nodes the same size. So you can see here that all of the nodes are the same size. And I apologize if there's not a better way to represent the organizations, but for now, I'm just using the 3-letter abbreviations. And so, for example, like PHI is physicians, this one's health insurers, this is local health departments, nonprofit organizations. That's something that the pretty features I'll build out later on. So you can also encode the edges based on weights relative to the smallest or largest node. And so this gives you a better sense of how much variability there is in engagement between organizations. And it can also help enlarge smaller nodes in the network and highlight influential actors. So for example, if we were to select the smallest node, so up here in the distorted view, this tells us that in rural networks, local health departments, hospitals, nonprofits, these organizations here that appear the largest are much more engaged in public health activities than the smallest node in the network, which in this case is the other organizations. Whereas the urban networks are all more similar in size. So we can see that nonprofit organizations have the most ties in the network, but all of the other organizations still play a pretty substantial role relative to nonprofits. And we can further explore specific relationships by switching to the circle layout. So here are all force-directed layouts. And we'll see that it's not totally clear here that the edge weights differ between rural and urban networks. But with the circle layout, it's easier to highlight these comparisons. So here, rural networks are shown on top. So basically the entire first row here, these are all showing rural networks in 2018, and then they're subdivided into these different types of governance structures. And the second row is showing non-rural networks. And each column represents local health department governance. So usually this is dictated at the state level, and local health departments can be governed by the state locally, or they can be governed both by the state and locally. And so here, as I mentioned, we have rural and urban networks in 2018 selected, and then we're comparing the networks whose local health department is governed either by the state, locally, or shared. And so first, if we wanted to compare rural and urban networks governed at the state level, we can see that rural networks are actually quite sparse. There's not a lot of cross-sector collaboration going on here. Urban networks are denser. There's definitely more involvement of these state health agencies, and that's right here. These state health agencies are collaborating with these other types of organizations. Then if we wanted to compare rural and urban networks governed at the local level, we can see that rural networks have a lot more cross-sector collaboration here compared to those that are governed at the state level. So there's a lot more, it's a much denser network than this network shown here. Federal agencies also play a more substantial role in rural networks governed at the local level compared to rural networks governed at the state level. So you can see here that federal agencies collaborate with several different types of organizations, and they play a very minimal role in the state governance structure. And many different types of organizations are involved in local public health networks in both rural and urban networks when they're governed at the local level. So it's a dense network, and it's also fairly well distributed. And then lastly, if we were to compare rural and urban networks governed at both the state and local level, we can see that rural networks actually probably have the strongest cross-sector collaboration when local health department governance is shared. Whereas for urban networks, public health networks probably have more cross-sector collaboration when urban networks are governed at the local level. So here, compared to those with shared governance structure. And to me, this suggests that maybe we shouldn't just care about simple rural versus urban comparisons, because not all rural networks in particular are the same. Cross-sector collaboration depends quite a bit on local health department governance. And so this is just one way that you could use this to better understand the differences that exist between different types of networks. And then I wanted to quickly highlight how the node link matrix can be useful. So this is underneath the either force-directed layout or the circle layout. We have the node link matrix. And this is more useful for looking at specific types of organizational ties. So say, for example, we wanted to look at the relationship between federal agencies and physicians, or federal agencies and state agencies. You can find federal agencies and then pick out these types of organizations that have the most collaboration with federal agencies. So basically, federal agencies jointly participate in a lot of different activities with these organizations. Similarly, you could look at the little yellow boxes and look at the relationship, for example, between health insurers and schools, and you would see that there is very little collaboration occurring between health insurers and schools, and that would be expected. So next steps, I would like to incorporate numeric measures for both edge width and the number of local health departments. So as I mentioned at the beginning, I'm basically taking like a weighted average of all of the local health departments that are selected for a specific criteria on the left-hand side, but it would be nice to be like, oh, you selected rural health departments from 2018, that includes 300 health departments. And then average edge width could show on average how many activities do these two types of organizations jointly participate in. So it'd be good to know, local agencies and local health departments on average participate in 8 shared activities, or local agencies and hospitals participate jointly in 12. Just numeric measures for what's shown in the graphs, which might not always be obvious. And then also allow users to highlight specific nodes and edges of interest. It can be kind of hard to see through like this entire force-directed layout and tell which lines are going where, but it would be useful if the user is able to highlight, okay, I want to see the relationship between federal agencies and other organizations. So that would be right here, or local health departments and local agencies, that would be right here. So you can really see where is the tie occurring. I also would like to include modifications for changing the number of comparisons. So this was in an initial version over here, but it would be nice to be able to allow the app to interactively change the number of columns that it shows to the user. So if you wanted to not just compare 2 years of data, but you wanted to compare all 6 years of data, we currently have 6 different waves of the survey. Or if you wanted to compare across 3 types of governance structures, for example, right now the app only allows for a comparison of 2. And then another thing that I think would be pretty valuable in the long run is allowing users to select local health department networks for specific activities. And so this is what I'm trying to build out now. And I apologize, it's not like the prettiest graph at this point, but I basically selected all of the assessment activities. And I think looking in more detail at specific activities sheds a lot of light into the types of activities that organizations are choosing to involve themselves in, the types of organizations that might be pulling them into public health activities, and also whether or not it's really adding value. Because activity 1 here is, in the past 3 years in your jurisdiction, has a community health needs assessment process been conducted that systematically describes the prevailing health status in the community? And most organizations are in some way involved in conducting community health needs assessments, except for federal agencies for the most part. So local agencies, local health departments, hospitals, nonprofits, et cetera, at the center of it. For many organizations, engagement and participation in community health needs assessments is the only public health involvement that they have. So if you were to instead look at activity 4, this question asks, are the necessary lab services available to support investigations of adverse health events and meet routine diagnostic and surveillance needs for your jurisdiction? Well, lab testing does not occur by all types of organizations, and you can see that it's most commonly conducted by state agencies, physician groups, hospitals, and local health departments. So looking at specific activities would be useful. And just to wrap up, some health equity implications. Understand the complexity and variability in local health department network structures. This app is basically able to inform potential areas for improvement and expansion of collaboration among organizational actors. I specifically designed this app to help me with my research questions, and I focus on econometrics research questions and hypotheses, but it could also be useful in assisting in building frameworks, theories, and models for dissemination and implementation research. And then could also assess local partnerships and collaboration through different phases, adoption, implementation, and maintenance in community settings. And thank you. With that, I will open it up to questions.
Thank you so much, Alex. We will now open the floor for the Q&A time. If you are willing, please unmute and ask your questions, or otherwise you're welcome to put your questions into the chat. Alex, to start off, I'm interested in knowing then how you actually utilized this app to answer your questions on econometrics. What were you trying to solve or think through?
Well, at the time, I had been looking at employer engagement in public health research and working on a more descriptive project. And I was trying to understand how employers were engaging with other types of organizations and basically what types of employer engagement is valuable and what's not. So this is more of like a descriptive project where I started out being like, I don't understand like the mechanism by which employers are engaging in public health. Like, is this truly to assist in public health activities, or is this because they have regulatory requirements? So I think I haven't yet incorporated it into actual econometrics research, but there are different types of, like, for example, exponential random graph models, I think are a potential application. I'm trying to build my dissertation aims at the moment, but I've been thinking about using this type of research to kind of come up with questions where I can look at graph theory and use graph theory for causal methods, which is not something that's frequently done at CU.
Impressive. Are you also, will this app eventually be available to the public? Because you were talking about how it really could be used by health service researchers, but I'm also thinking when you talked about being able to drill down to specific public health activities, how useful that would be for state and local public health agencies.
I'm not opposed to it. I think it depends a little bit on funding. But one of the potential applications, so we just conducted like the 2022 wave of the survey. And every year for local health departments that participate in the survey, we'll send out like a report, like, here's what your local health jurisdiction looks like. Here's how it compares to other similar types of jurisdictions. And I think it gets a little tricky because I think that I'm fine with disseminating this app and allowing others to use it, but you can't let specific health departments access data where they can identify health departments other than their own. So it would have to be specific to the health department or like really high level where they can't really drill in on another specific health department that they were interested in.
Got it. All right, from the chat, there was a question then, what was the most surprising thing you discovered in your analysis?
I think I had been, especially being in Colorado, like been pretty interested in the rural and urban comparison. I didn't expect to see so many differences in the types of collaboration that formed in states that had different types of governance structures. So I mean, I guess it kind of makes sense when you think about it, but states that are governed at the state level, those rural areas are really kind of screwed. And I think there's an expectation from federal agencies that states will get involved and really help foster collaboration at the local level, but we can see that's not happening in rural jurisdictions. Whereas in states that are governed at the local level, I think federal agencies are more likely to be like, hey, we think these people probably need some help, so we're going to step in and partner with these types of organizations. So I was just surprised to see so many differences in how the network structures varied across these various components. Like you can also see pretty substantial differences between city local health departments and county local health departments. And a lot of it makes sense when you think about it. But I think also if you're thinking about how to improve a specific local health department, you want to think about like which organizations have an incentive to get involved in public health in the first place, and what other types of organizations are most likely to engage these organizations in the first place so that you can bring them into the public health network.
Thank you. And another question in the chat was, does more varied and or more frequent networks result in better public health outcomes?
Frequent being, no.
Maya, do you want to?
Yeah, I meant more like collaboration. So my understanding is you're looking at the different, what agencies are collaborating with each other at, and at what maybe frequency or how strong those ties are. And I was just wondering if you could speak to some of the public health outcomes of those collaborations. I came in late, so if you already answered that, you can.
No, I haven't. My PI has, well, he spent a lot of time, I think about 10 years ago, in categorizing local public health departments into like 7 different categories, which is that cluster typology variable that I was talking about at the beginning. And it kind of, yeah, so there are clear differences in how well these local health departments deliver public health to their communities. And also it does have an impact on outcomes because people in our department have looked at that. So like we kind of know generally that denser networks are better, like more collaboration is almost always better. But what we don't understand is that like which types of collaboration are beneficial, what types of activities. We don't understand a lot of like the fine details about yeah, in communities that deliver more public health activities and have more organizational involvement, they probably end up lowering their rates of chronic disease over time. But specifically, like what types of partnerships and which types of public health activities are contributing to that, that's not something that we know. And it's also, it's really hard to gather from the format of the data that we currently have, which is kind of why I wanted to start by visualizing this data and looking for hints as to what would actually be happening behind the scenes. If anyone has any thoughts or recommendations or thoughts on like specific types of activities that impact, like we can ascertain that if communities implement more types of assessment activities, they do a better job of keeping tabs on maybe rates of chronic disease or rates of lead poisoning from health exposures in their environment. But I think what I was starting to see when I was looking at the data descriptively was that it's not just like you can't just have one type of public health delivery. You can't just have assessment activities and not have policy and assurance activities as well to actually impact health outcomes.
So another sort of comment came in saying that it would be interesting to see network density in a community and its level of social connectedness.
I totally agree. And one of the girls in our group is looking at social connectedness and loneliness, and I think she's using this data, so that would be interesting.
It would be super cool though to also, as you're discussing, be able to whether it's by local jurisdiction or state jurisdiction, look at the network density across, like both the assessment all the way to assurance, and see how that all matches up. And if you're actually able to see density across the space, then that might actually indicate better health outcomes in those specific jurisdictions.
Yeah, and I think I hadn't looked at specific outcomes, but I had looked at, I think there's a question on the survey that asks about like, what is your perceived effectiveness of the delivery of these types of activities? So I had looked at whether how perceived effectiveness changed based on the basically combinations of activities that were implemented. And it was interesting because I think there were like 2 or 3 different combinations of activities that could result in really high effectiveness of public health implementation in communities. And it was never the communities that had really high policy engagement and nothing else. And the more assurance engagement, the better, but it could be like a combination, communities that had a combination of like a lot of assessment and policy engagement had a lot of success in people perceiving their public health infrastructure to be really effective. And then similarly, I think if you have a lot of assessment activities that are being performed in your community, you need some level of policy and assurance engagement as well to actually have a meaningful impact, or perceived effectiveness is quite low. So still definitely more research to do there, but it's interesting.
Yeah, there's a lot of opportunity. Well, I want to thank everyone for attending this session and for also engaging in this question and answer period. A few short announcements before you all head out. Slides and any additional handouts from the speaker will be available on Sketch. Also, after this conference, you'll receive an evaluation via email. Please fill that out, even if you've only been to a portion of the conference itself. There will be a raffle for everyone who completes the survey within 2 weeks, and you could also win one of 2 $50 gift cards. Right now, we have a break for lunch. And also to give you some time to listen to a recorded walk and talk session. So as you step away from the screen, that is. These are audio only sessions, so they're like a podcast, and the featured one for this break is entitled Promoting Health Equity Through Program Evaluation Partnership. The next live session will begin at 12:30, and it's another concurrent breakout. So you can choose the session in which you want to go to. Please see the full schedule on Sketch to determine which breakout you'd like to attend. So thank you all, and have a wonderful rest of the day. Bye.